Welcome to this free deep dive in our Journal Club series. If you are a resident preparing for board exams, like the FRCS and plastic surgery, this is exactly where you need to be.
Right, because we are getting straight into their high-yield question and explanation style content you need. But first, let's be direct. Do not waste time with passive studying.
Exactly. Head over to medsynclimited.com right now and get the FRCS Plastic Surgery Anki Deck. It has over 7,000 questions arranged by topic to turn your revision into active recall.
It is entirely based on the plastic surgery curriculum. It's really the go-to companion exam question guide.
Yeah, it's a lifesaver. And since this is a free Journal Club deep dive, make sure you get a membership to access the full library of premium clinical cases and Journal Club discussions on the go.
Absolutely. So let's dive into today's source material. We are unpacking the United Kingdom National Multidisciplinary Guidelines for the Investigation and Management of an Unknown Primary with Metastatic Neck Disease.
Right. And the mission today is to solve a medical mystery. Imagine a patient walks into a clinic with a cancerous, maybe golf ball-sized lymph node in their neck. But when you go looking for the primary tumor where the cancer actually started, it's completely invisible.
It is the absolute definition of diagnostic muddy waters. And for the FRCS exams, you need to understand the precise, highly structured detective work doctors use to track down this hidden culprit.
Okay, let's unpack this. We have a patient with a lump. It gets biopsied, and it turns out to be a squamous cell carcinoma in a cervical lymph node. But we search the entire head and neck for the index site, and we find absolutely nothing. What is the actual definition here?
An unknown primary is strictly defined as a squamous cell carcinoma presenting in a cervical lymph node where no primary index site in the head and neck can be identified.
And just for context, how rare are we talking?
It's very rare. It represents only about 1 to 2% of all squamous head and neck cancers.
Which is exactly why these multidisciplinary guidelines are so crucial. We don't have, massive randomized trials because the patient pool is just too small. So let's talk clinical presentation. How do these patients usually show up?
Usually the mass is found in the level 2 or level 3 lymph nodes. And surprisingly, less than 10% of cases report pain or dysphagia.
Dysphagia, so difficulty swallowing.
Right. The patient usually feels completely fine, which makes finding a malignant mass pretty jarring.
But the location of that painless mass is a huge clue. It's like finding a getaway car in a specific zip code to guess where the hideout is. The guidelines outline this first echelon map in Table 1.
Exactly. The human lymphatic system has very predictable drainage patterns.
So if a node is in level 1, right up under the jawline, that points to the oral cavity.
Spot on. And what if it's in level 2?
Level 2 points to the oral cavity, but also the larynx and pharynx. And level 4 indicates the larynx or esophagus. And level 6 points straight to the thyroid.
Correct. You use the node level to guide your search.
But wait, let me push back on this geographical mapping for a second. Gravity is a thing. If you find a lump really far down the lower neck, say near the collarbone, a supraclavicular node, couldn't that just mean a head or neck cancer traveled further down the chain?
What's fascinating here is that finding supraclavicular lymphadenopathy usually represents a totally different clinical entity.
Wait, really? Like it's not from the head or neck at all?
Right. The guidelines warn that it might be an infraclavicular neoplasm. Cancers from the lungs or stomach can actually back up the thoracic duct and present in the lower neck.
Oh, wow. So you could spend weeks aggressively searching the throat and completely miss a lung cancer.
Exactly. So location is critical. But we also have molecular clues. For example, if you see a cystic, fluid-filled metastasis in level 2, what does that indicate?
That is a classic hallmark of an HPV-related carcinoma, which is usually hiding subclinically in the oropharynx. And conversely, if you find the Epstein-Barr virus EBV, that points incredibly highly to a nasopharyngeal site.
Yes. So we use physical and viral clues. But how do we actually get those cells to test? The guidelines are very specific about biopsies.
Right. They state a core biopsy is preferred over a fine needle aspiration, or FNA. Which, an FNA sounds less invasive for the patient.
It is, but an FNA just vacuums out a jumble of disconnected cells. A core biopsy is crucial because it gives a clearer histological picture and preserves the actual cell architecture.
And it gives you enough tissue to run P16 staining, right?
Yeah.
Which we use as a surrogate marker for HPV status.
Exactly. So we have our clues, but we still need to visualize the invisible tumor before surgery.
Which brings us to the imaging standard of care. The PTCT fusion scan.
Right. Now, what are the stats on the PTCT for finding these unknown primaries?
Well, it has a 44% identification rate, which doesn't sound great.
Mm.
It has a high sensitivity of 97%, but a much lower specificity of 68%.
And what does that low specificity mean in practice?
It means false positives are a massive issue.
Mm.
It's lighting up benign tissue. And this dictates the most important timeline rule in the guidelines. You absolutely must do the PTCT before any panendoscopy or biopsies.
This is a classic exam trap. Why is that timing so critical?
Because if you do the panendoscopy first, where you're under general anesthesia looking at the upper aerodigestive tract with straight and angle telescopes, and you take a biopsy, you cause trauma.
Right, and trauma causes inflammation.
Yeah, white blood cells rush in, they consume tons of glucose to heal the area. So if you do the PT scan after that, the radioactive sugar tracer pools in those healing spots.
Effectively mimicking cancer.
Exactly. You are tampering with the crime scene. You ruin the radiological accuracy.
Spot on. Always image before instrumentation.
Yeah.
But even if the PTCT is totally clear and the panendoscopy shows zero suspicious tissue, the guidelines recommend removing lymphoid tissue anyway.
Yeah. They recommend a bilateral tonsillectomy. And if facilities exist, doing a tongue-based mucosectomy via torus transoral robotic surgery to remove the lingual tonsil.
Which often surprises residents.
Yeah, I mean, wait. If the PTCT has a high false positive rate, and we are taking out both tonsils just in case, aren't we risking unnecessary surgery on a false alarm?
It sounds aggressive, but it's not a mistake. Squamous cell carcinomas love to initiate deep within the tonsillar crypts.
So they are microscopic and hidden in those deep crevices.
Right. They evade the PT scan and the scopes. The bilateral tonsillectomy is a proven net to catch microscopic primaries that imaging just misses.
Okay, here's where it gets really interesting. Let's say we do all of that. Tonsils are out, scans are clear, scopes found nothing. The multidisciplinary team officially declares it a true unknown primary. How do we stage this for the exams?
The T stage for an unknown primary is officially designated as T0, not TX.
And I always want to push back on this nomenclature. Why is it called T0 instead of TX? I mean, TX sounds like unknown, whereas T0 sounds like zero tumor exists.
Yeah.
But we know a tumor exists because of the neck node.
It's a great question. It comes down to clinical intent. TX implies an incomplete evaluation, like maybe the patient couldn't tolerate the scan.
Oh, so it's like a placeholder.
Exactly. But T0 is a definitive statement. It means that despite an exhaustive, standardized investigation, no primary was found in the head and neck. It says a specific baseline for the treatment protocol.
Got it. Okay, so let's walk through those treatment algorithms from Table 2. The overall goal here is curative intent, minimizing morbidity to the aerodigestive tract.
Because the natural history shows that the primary tumor eventually emerges in about 3% of cases per year.
We literally have to treat a ghost. Let's start with T0N1 disease with no extracapsular spread.
Okay, so a single node, cancer is fully contained within the capsule. What's the treatment?
For that, it's surgery alone. A modified radical neck dissection or a selective neck dissection. No radiation needed.
Correct. But what if that T0N1 node has extracapsular spread?
Then it changes completely. You still do the neck dissection, but you have to add radiotherapy, and you strongly consider chemotherapy.
Right, because the cancer broke through the node's shell into the surrounding neck tissue. And for advanced stages, say T0N2 or N3.
That requires comprehensive clearance, neck dissection, potentially bilateral, plus radiation and chemotherapy.
And it's worth noting that for massive N3 disease, surgery might only be palliative just to prevent the nodes from fungating.
Right, fungating meaning the tumor basically bursts through the skin, which is awful. So once surgery is done, we pivot to mopping up the microscopic disease. And this is a huge balancing act.
Yes. The major debate in the oncology community is how broadly to apply radiation, total mucosal irradiation, or TMI, versus targeted radiation.
It's like carpet bombing versus a sniper approach. Yeah. TMI aims to radiate the entire mucosal lining to eradicate the invisible primary. But the cost is severe chronic morbidity.
Primarily xerostomia, which is extreme dry mouth.
And that shatters quality of life. Patients can't swallow properly, their teeth decay. So if a center uses TMI, the guidelines highly recommend IMRT intensity modulated radiation therapy.
Because IMRT allows us to deliver different doses to target areas while sparing the salivary glands. The mature data yields 94% locoregional control and 89% overall survival at 5 years.
If IMRT is so effective at preserving quality of life and targeted radiation is an option, why is TMI even still a debate?
It goes back to the rarity of the disease. With only 1 to 2% of cases, there is a serious dearth of randomized literature.
So doctors are just relying on individual center case series.
Exactly. Clinicians are forced to constantly weigh the fear of a primary tumor emerging later against the guaranteed immediate damage to the patient's salivary glands.
It's a brutal choice. Okay, for the exams, we need to know the specific radiation dosages. A post-operative neck gets 60 gray, usually over 30 fractions.
Correct. And if there is extracapsular spread,
That bumps up to 64 to 66 gray.
bleh.
If there is gross microscopic disease left behind, it gets 70 gray. But uninvolved neck or putative sites only get 50 gray.
Spot on. And radiation is rarely given alone for advanced disease. What's the chemotherapy standard?
Concomitant platinum-based chemo, specifically cisplatin, given at the same time as radiation.
Yes. The data shows it improves locoregional control by 13% and reduces the risk of death by 30% at 5 years.
Now, you can use neoadjuvant chemo like docetaxel, cisplatin, and 5-FU for cytoreduction in gross unresectable disease.
Meaning you shrink it before surgery or radiation.
Right. But, and this is a big exam point adjuvant chemo, meaning chemo after all the radiation and surgery is done is not recommended.
Correct. It just adds toxicity without proven survival benefit.
Okay, so the patient has survived this grueling treatment. What does the follow-up schedule look like?
It's intensive. You see them every 4 weeks, up to 18 months, or at least every 2 months for the first 2 years.
Because the highest risk of relapse is in those first 2 years. And then it spaces out to every 3 to 6 months in subsequent years, up to a minimum of 5 years.
But the critical imaging milestone is the 3 to 4 month PT-CT scan.
Right. You wait 3 to 4 months, so the radiation inflammation subsides. And if that scan is negative, it has a massive negative predictive value of greater than 95%.
Which offers huge reassurance to the patient and the team.
So what does this all mean for you as you study this? We've covered the guidelines, the staging, the treatment, but there is a final lingering mystery here.
The biological behavior of the tumor.
Yeah. Think about this for a second. If a metastatic lymph node can grow large enough to be clinically detected, what is actually happening biologically to the original primary tumor?
Right. How does it just vanish?
Is it possible that the body's own immune system successfully attacks and destroys the primary tumor at the mucosal site, but at the exact same time completely fails to recognize and stop the metastatic spread in the lymph nodes?
It's a fascinating paradox. The immune system wins one battle, but completely ignores the other just inches away.
It really is. So we invite you to ponder this immune system mystery. Keep exploring the fascinating complexities of human biology as you prepare for your exams.
And remember to rely on active recall.
Absolutely. Go to medsynclimited.com, grab that FRCS Anki deck, and get a membership for the full Journal Club library. Please leave a comment or question below. We'd love to hear your thoughts on this case. Keep studying hard, and we'll see you on the next deep dive.